It is my pleasure to introduce Dr. ANDRA James. She is a professor of obstetrics and gynecology in the Division of Maternal Fetal Medicine and a consulting professor of medicine in the Division of Hematology at Duke University. She has published extensively and is involved nationally and internationally to improve health care for women with blood disorders. She is currently president of the Foundation for Women and Girls with Blood Disorders. She has served on multiple medical and scientific advisory committees and boards with the National Hemophilia Foundation, Platelet Disorders Support Association, National Blood Clot Alliance, and Hemostasis and Thrombosis Research Society. She has been chair of the Women's Task Force of the National Hemophilia Foundation, chair of the Women's Issues Scientific Subcommittee of ISTH. She was special advisor to the director of the Division of Blood Diseases and Resources at the National Heart, Lung, and Blood Institute, NIH. And last year, she was awarded the Lifetime Achievement Award by the Hemostasis and Thrombosis Research Society. We're very pleased to have her here today. She's going to speak to us on special considerations for delivery of a baby to a mother with a bleeding disorder, a close look at hemostatic preparation and delivery issues.
Thank you.
Dr. James.
It's certainly a pleasure and honor to be here today. I want to thank Rochelle, Pam, David, and the organizers for allowing me to come. And I also want to thank you for allowing me to talk about an obstetrical topic rather than a gynecologic topic, because actually my fellowship was in maternal fetal medicine. About 15 years ago, I was asked by the National Hemophilia Foundation if I would give a talk at their national meeting. And I said yes, if I could talk about anything but menorrhagia. So a few months later, I got the program, and the title of my talk was Anything But Menorrhagia. It was a little difficult to work with, but I got something out of it. In fact, I stood there during several inhibitor talks and wrote up a paper, and then that was actually published in Hemophilia after one of the reviewers, who I later inferred was Peter Coides, made me put in about 5 evidence tables. What a lot of work. But anyway, thank you for the opportunity to talk about obstetrics. So I don't have any disclosures that are pertinent in the last year. And I want to frame my talk with a recent case that came to my attention. A young woman was pregnant with her first child. The pregnancy was uncomplicated. Her past medical history was unremarkable, but the obstetrician had duly noted in her chart that she had a maternal uncle with hemophilia. So the special considerations that I can come up with include actually verifying whether the mother has a bleeding disorder or not, what are the bleeding risks to her, what are the bleeding risks to the baby, who should care for the mother during pregnancy, where should the mother deliver, and who should be involved. And these are questions that frequently the Hemophilia Treatment Center staff are asked. So does the mother actually have a bleeding disorder? Well, using our case as a framework, this woman actually was a possible carrier, not an obligate carrier, but a possible carrier, because she was the niece of a man with hemophilia. And our guidance from the National Hemophilia Foundation of the United States is that women who are at risk of being carriers for either hemophilia A or hemophilia B should have their bleeding disorder status determined before they become pregnant, or at least early during pregnancy rather than at delivery or afterwards. And if clotting factors are inconclusive, genetic mutation analysis should be offered to establish a definitive diagnosis. and women and families should become acquainted with the methods of diagnosing a potentially affected infant prior to delivery and should be aware of the option of pre-implantation genetic diagnosis, as well as the definitive invasive prenatal diagnostic test during pregnancy, and also know that there is cell-free fetal DNA, which now can determine fetal sex, or our standby ultrasound to determine fetal sex. What are the bleeding risks to the mother, if indeed she has a bleeding disorder? Well, we've spent some time talking about that this morning. And we've also alluded to the fact that even in a woman with a bleeding disorder, most bleeding at the time of delivery is actually obstetrical bleeding. And what do I mean by that? I mean the bleeding that occurs after the placenta detaches, bleeding from that placental site that is potentially aggravated by failure of the uterus to contract or retention of some of the placenta or other products of conception. This can occur anytime in pregnancy when the placenta detaches. We call that obstetrical bleeding. I should point out that only about 1% of a woman's blood volume flows through the uterus in any given minute when she is not pregnant, as opposed to at the time immediately prior to delivery, 15% of her blood volume is flowing through the uteroplacental circuit. So it is hard for any number of clotting factors or platelets to stem that tide without the cooperation of the uterus. Less often, bleeding at the time of delivery is surgical from incisions or lacerations, but sometimes it is due to a pre-existing bleeding disorder. And occasionally, an acute acquired coagulopathy as a result of any of the previous three. So what are the kind of bleeding disorders we deal with at the time of delivery? Thrombocytopenia, perhaps the most common, platelet dysfunction, von Willebrand disease, hemophilia carriership, factor VIII and factor IX deficiency, and occasionally a rare bleeding disorder. Now, in our favor, women have evolved so they're protected against the bleeding challenges of pregnancy. Their clotting factors increase. Even though platelet number frequently goes down, platelets are actually bigger and probably more robust during pregnancy. And specifically, factors VIII and von Willebrand factor increase during pregnancy. Factor IX is much more static. These are data from a prospective study we did with 4 other centers looking at von Willebrand factor and factor VIII levels in women with and without von Willebrand disease. And I don't have on here the women who were treated. Their line looks a little bit more erratic, but this is women, von Willebrand factor levels in women without von Willebrand disease. This is factor VIII levels in women without von Willebrand disease. And this is von Willebrand factor levels in women with von Willebrand disease and factor VIII levels in women with von Willebrand disease. But these women were not thought to have levels low enough that they required treatment. Nonetheless, their levels never achieved parity with women who did not have von Willebrand disease, and in fact paralleled the levels in women without von Willebrand disease, but were lower at every time point, suggesting that even women who don't require treatment may be a little more vulnerable. Now, what are in prospective studies, what are the risks, bleeding risks to women with an underlying bleeding disorder? Most of our data comes from population studies and in women with von Willebrand disease, because that's where the numbers are highest. And in a study of a large United States national database, we found that antepartum bleeding was 10-fold higher in women with von Willebrand disease. Postpartum hemorrhage was 50% higher, and perineal hematoma was about three times higher, even though that didn't reach statistical significance. And severe postpartum hemorrhage was 3 times higher in a United Kingdom database. There are other studies that have reported even higher levels of postpartum hemorrhage in women with bleeding disorders, von Willebrand disease, or hemophilia carriership. But those studies were done retrospectively, and those studies often relied on patient recall, were not verified with admission for postpartum bleeding or transfusion. But even in these prospective studies where that was verified, the numbers are still higher than, the risk is still higher than it is for women who don't have these bleeding disorders. So what are the bleeding risks to the baby? The most bleeding in a severely affected infant or male with hemophilia is manifest at the time of a circumcision. That is actually me doing the circumcision. I was once asked in a debate how I felt about circumcision. You can see that this is not the gender that I usually work on, not the age group I usually work on, and not the anatomy I usually work on. So I let them know that independent of anything to do with hemophilia, I was not in favor of circumcision. It is, however, the number one site of bleeding in infants with hemophilia from data we have from the Centers for Disease Control registry. Then almost a quarter of the bleeding is cranial bleeding, and half of that is intracranial bleeding. So if you've been in this community any length of time, you know that the risk of intracranial bleeding is likely related to the mode of delivery. So from that same Centers for Disease Control database, which has the largest number of affected infants on whom we have this information, vaginal delivery was associated with a 2.8% rate of intracranial hemorrhage, and cesarean delivery was associated with a 0.5% rate. And this is actually not, this is not limited to cesarean delivery before labor. This can include cesarean delivery after a difficult labor, which is potentially associated with more trauma. So even then, the odds of intracranial hemorrhage are 8 times higher with vaginal delivery. And we know from babies that do not have hemophilia and just population data in general that operative vaginal delivery, forceps or vacuum, confer a risk twice what spontaneous vaginal delivery does. So who should care for the mother and baby? Well, as Dr. Winikoff said, it takes a village. It takes a multidisciplinary team. And the cornerstone of that team is the hemostasis expert. But also, we'd like the family to have seen the genetic counselor during pregnancy, obstetrics and/or maternal fetal medicine, an anesthesiologist in anticipation of delivery, a pharmacist to help prepare products, and a pediatric hematologist in anticipation of the potentially affected infant. And I frequently get asked, where should the patient deliver? And I will get answers, or I will get statements such as, well, we have a blood bank that has cryo and FFP in it, so she really doesn't need to come to your tertiary care center. Well, for the affected woman and her affected baby, the woman with factor levels, that's supposed to be 50%. Goodness knows where that comma came from. Or with a history of hemorrhage, or with a potentially affected baby should deliver where the multidisciplinary team is, where there is an adequately stocked blood bank, where there are hemostatic agents available, where factor concentrates are available, where a massive transfusion protocol is in place, and where there is a newborn intensive care unit. And what is the treatment? Well, women with bleeding disorders, von Willebrand disease, factor 8 or factor 9 deficiency, should receive factor replacement prophylaxis at the time of delivery, usually if their factor levels are less than 50%. and when available, that should be with recombinant or virally inactivated clotting factor concentrates as opposed to fresh frozen plasma or cryoprecipitate. And women with factor levels above 50% should be given the option of regional anesthesia. And Dr. Rivard will speak to us more on that subject. Now, what about desmopressin? It certainly can be used during pregnancy to raise von Willebrand and factor VIII levels prior to procedures, but it can cause fluid retention and can cause hyponatremia. The United Kingdom guidelines say that it should not be administered in the setting of more than 1,000 milliliters of fluid in 24 hours. Women routinely get 2.5 to 3 liters just at the moment of delivery, not to mention all that they get during labor. So that turns out to be a setup for fluid retention. So at the time of delivery, desmopressin must be used with extreme caution, if at all. In that prospective study of women with von Willebrand disease that I alluded to earlier that we did with 4 other centers, there were 35 women with von Willebrand disease who had 32 pregnancies. And 15 women out of the 32 were treated in 17 pregnancies. So I put this slide in here not so that you could read it, because I don't think you can, but so that you could get the idea of the very variable treatment regimens. No pregnancy was treated the same way in these 17 pregnancies, even among the 2 women who had 2 pregnancies during the study period. Every pregnancy was treated differently and received postpartum prophylaxis ranging anywhere from 0 to 21 days with von Willebrand factor concentrate. And 1 woman got desmopressin before delivery. So we don't have really a standardized approach to this situation. And these are data from that study as well. And these are modified pictorial blood assessment chart scores by week in women in green without von Willebrand disease, in blue in women who had von Willebrand factor levels greater than 50 going into labor, and in the red, women who had von Willebrand factor levels less than 50 and were treated. And you can see in those first couple of weeks, those levels are parallel to one another. But after 3 weeks, when our women who required treatment were not getting any more treatment, yet were still bleeding, because women do bleed up to 6 weeks after delivery, their scores became divergent, and they had considerably and statistically more bleeding. That's me, not the baby, this one. Doing a C-section. So the obstetrician should have a discussion with the woman who's expecting a severely affected baby about the mode of delivery. A woman who's not expecting a severely affected baby can deliver vaginally, maybe with some limitations on invasive procedures such as scalp electrodes or operative vaginal delivery. But for the woman anticipating a severely affected baby, she should have a discussion about the pros and cons, and the option of a planned cesarean should be recommended when an affected or potentially affected infant is anticipated. And in those women who elect vaginal delivery, forceps and vacuum interventions that double or triple the risk of intracranial hemorrhage in affected infants should be avoided. I was recently contacted by a lawyer for a woman who was a hemophilia carrier who told her obstetrician gynecologist that she was a hemophilia carrier. She was carrying a male who was potentially affected. He told her, Emily, this is for you, that she shouldn't worry about that she was going to be fine. The baby got to the point, and she said, well, I know that I should not be delivered by forceps or vacuum. Well, the baby got to the point of no return in the pelvis. Actually, the only people I know who can predict whether a baby should or should not be delivered by a C-section or vaginal delivery, or people outside of the obstetrical profession. Those of us who actually have delivered babies know that it's not that easy to predict which babies will successfully come out and which won't. And that was true in this obstetrician's case. He delivered the baby with forceps. The baby had an intracranial hemorrhage, and the baby has permanent neurologic damage. So those are the fetal issues. So what if the patient herself, though, actually starts to bleed? I've alluded to how we can think about this and potentially prevent a hemorrhage in the mother. Well, number one, the first thing to do is identify and sort out the cause. Is this 4% of women, 3 to 4% of women actually have a postpartum hemorrhage. About 1% require transfusion, and that's independent of whether they have a bleeding disorder. And it's important to identify the cause, because 80% of all postpartum hemorrhage is due to failure of the uterus to contract. So, and that may not be responsive to clotting factor replacement. Most of the rest of the 20% is due to surgical bleeding, incisions or lacerations, and they have to be addressed. The massive transfusion protocol should be addressed. Labs should be monitored. We will have that video available on point-of-care testing in this situation. Historically, we've used a PT and a PTT, fibrinogen levels, and eyeball. Is it oozing or not? No matter the cause of postpartum hemorrhage in a woman with a bleeding disorder, factor deficiency should be corrected. Anesthesia and critical care should be involved. And in the United States, we're not as good as utilizing hemostatic agents as you are here in Canada or they are in Europe, but we're getting better, including tranexamic acid, fibrinogen concentrate, and recombinant factor 7A when all else fails. We do have good support for using tranexamic acid. We have the results now of the woman trial, a large randomized trial that enrolled over 20,000 women and randomized women who had postpartum hemorrhage to 1 gram of tranexamic acid or placebo, with the option to repeat the tranexamic acid if bleeding persisted. And what we learned from that randomized trial was that the women who received tranexamic acid were statistically less likely to die from bleeding than women who did not receive the tranexamic acid, with no greater risk of thromboembolism or renal failure. So I told you about one case in the middle, but in the beginning I told you about the patient who was the hemophilia carrier, or potentially the possible hemophilia carrier, who's the young woman whose uncle had hemophilia. It turned out that she got no genetic counseling during pregnancy. She had no factor levels checked. You can see where this is going, or potentially going. She was not offered a cesarean delivery for her potentially affected male infant. She had a vaginal delivery, and the baby came out fine. Then the baby went to circumcision, and the baby did fine. And then the baby had a small bump on the head at 4 weeks of age, had a massive intracranial hemorrhage, subsequently developed a high titer inhibitor, and the attorney for the family thinks the obstetrician should have been a little more proactive in the beginning of the pregnancy. And we might agree. So in summary, our special considerations include confirmation of a bleeding disorder, assessing the bleeding risk to the mother, to the baby, assembling the care team, and planning for the delivery. Thank you very much for your attention and the invitation.
Are there Are any questions? If not, I'll start. Dr. James, is there any role for, in some of the severe cases, we saw some data at the beginning, and you alluded to it here, that some patients with bleeding disorders can have antepartum bleeding. What I understand is it very rarely, except with the exception of the rare inherited bleeding disorders, the von Willebrand and the platelets, they have some antepartum bleeding, but it very rarely, at least according to the data we have, culminates in miscarriage, from what we know now. The question is there a role for antepartum prophylaxis in the patients that have already shown themselves to be bleeders in the antepartum period? We often talk about prophylaxis before delivery. We don't talk about it in the woman that comes in with an almost miscarriage because of antepartum bleeding. I don't see it in the literature at all.
Yes.
And we had a case recently that I questioned that a patient who has a severe, von Willebrand type 3, who came in with a placental problem, who bled. And she ended up going into premature labor. But the point is that when she had the threatening bleeding, should she have been on prophylaxis at that time in the antepartum?
So I'll get around to answering the question. I do want to say that we do believe women with fibrinogen deficiency or factor 13 deficiency are at increased risk of miscarriage, and we don't with respect to the other bleeding disorders, and that's also our clinical experience. And we have not deployed prophylaxis for von Willebrand, for women with von Willebrand disease or hemophilia carriership, except for the handful of type 3 von Willebrand patients that we have seen. We are not exactly sure what we're treating in that situation because 20% of women bleed during pregnancy, whether they have a bleeding disorder or not. And they can bleed to 20% of women who ultimately carry their pregnancy to term bleed during pregnancy. So we're not sure what we're bleeding, but we have this sense that a woman with type 3 who has undetectable levels is going to bleed more, and that potentially could stimulate uterine contraction because we know that blood and thrombin provide positive feedback to help the uterus contract. So we don't know if we're making a difference. We certainly aren't going to prevent a miscarriage or prevent adverse placental mediated outcomes with clotting factor, but we may reduce the amount of bleeding that they have in those precarious situations. Does that answer the question?
I know that you've been writing about it, that you have been debating about it, the issue of decision ahead of time that we are going for a C-section or we are going for vaginal delivery when the baby is known to have hemophilia. Can you sum up your opinion for this group for us?
Yes, so it boils down to the fact that the risk of neurologic injury is actually higher in that situation than it is for other conditions where we would resort to a cesarean. Like we resort to a cesarean if a woman has a herpes lesion on her vulva, where the risk of a neurologic injury from her vaginal delivery for that reason is much lower than the risk of a neurologic injury from an intracranial hemorrhage in a baby with hemophilia. And I think part of the problem is that we don't have crosstalk between our hemostasis experts and our obstetricians. This is a condition that occurs in 1 in 5,000 cases. That's about how many deliveries an obstetrician does in a lifetime. So the obstetrician is going to have one experience with a hemophilia baby. And so we have to rely on our families themselves to bring this to providers' attention, to advocate for themselves, and bring it to the attention of the hemostasis experts who can help assemble the team at the time of delivery. Also, one of the objections to cesarean delivery is the risk to the mother. There are 2 fabulous randomized trials, not in the case of hemophilia because that would never be done, but they were done. One was done for breech and one was done for twins. where women were randomized between a planned vaginal delivery and a planned cesarean delivery. And the maternal risks in the breech study were no different. Because planned vaginal, that may seem counterintuitive, but a planned vaginal delivery includes all the emergency C-sections that are done for that reason. When the anatomy is distorted, she's at greater risk of infection, she's more likely to bleed than in the setting of a planned C-section. So the risks were the same in the breech trial. In the twin trial, the bleeding was actually higher in the vaginal delivery group than in the planned C-section group. So as far as the risk to the mother, we can't really fall back on it'll be more protective to her because overall C-section carries greater risk than vaginal delivery, but that's not the way that should be looked at. It needs to be looked at as planned vaginal delivery versus planned cesarean. So, and in the United States, 1 out of 3 babies is born by cesarean for a lot more trivial reasons than this.
Yeah. So, Andy, great talk as usual. I had one brief comment and then a question for you. The comment is that actually about 3 times a year we deal with the problems you just described with our dogs. So the issue
hemophilia
about
dogs.
the hemophilia dogs. And we have now decided actually to do planned C-sections. We do this routinely. So having the team there at the right time to deliver the 5, 6, 7 pups, and our success rate has been pretty good, actually. I mean, but every time we're faced with this, we're faced with the same sorts of issues that you're describing here, but with multiple offspring, I guess.
You remind me of, well, I have 2 comments about that. Something that Tim Nichols, who has the dog colony at Chapel Hill, had shared with me, or we discussed, and something that happened when I took my dog to my dog who had leukemia was referred to the dog oncologist. And I sat down with the dog oncologist, having spent the equivalent of a year in GYN oncology during my OB/GYN training. And I raised all the issues about subjecting a dog to chemotherapy, loss of hair, vomiting, et cetera. And the dog oncologist said, well, we wouldn't treat a dog that way. So we're worried about quality of life. So I think that the fact that we will protect our dogs with C-section, we should then think about protecting our unborn babies. And a dog, the size of a dog fetus head compared to a dog pelvis is like this compared to this. A chimpanzee fetal head is about this size compared to a chimpanzee pelvis, which is this size. So it should come out a little easier with less trauma. Australopithecus head, about this size. Australopithecus pelvis, this size. Human head, this size. Human pelvis, this size.
I don't know if, can I have one very quick question? So type 2B von Willebrand disease, you had 3 in your case series. I mean, they are very difficult because of the thrombocytopenia that occurs both in the mum and in the fetus, I guess. So do you have any words of wisdom about looking after the 2B VWD cases?
I don't. Requires a good hematologist.
Thank you very much.